could be.
The blind leading the blind.
Well, it's it used to work like this.
All right, I am going to move along because a lot of what I say is to agree with Mary on deprivation of liberty, for example, so I'm not going to overburden it. What I am not going to do, unfortunately, is solve the assisted decision-making capacity bill because it is enormously tricky and difficult to follow. Thanks very much.
Just go forward.
Yeah.
The error provision.
Okay. So it's a mixed bag. There are good bits and there are bad bits, and I'll take you through the bits I like. The good bits are the basic principles. Basic principles are lovely. They're based on the Lower Firm Commission report. They say all the right things. Right spirit is there. All brilliant. The problems come later. It's enormously complex. It's unnecessarily wordy. It gives you a headache trying to read and understand it. There is reliance on working groups and later codes of practices. It's probably unavoidable, but it means that that bill, even if it passes, is not going to hit the ground ready and running to be implemented properly. Some of the specific provisions undermine the general principles, in my view, and the deprivation of liberty safeguards. It's functional capacity. There are some essential problems. A great idea, functional capacity, but intrinsic to it is if you have a separate capacity for every single decision you make every day, that's a lot of capacity judgments potentially. Any of you could lack functional capacity to make a very complex decision. We don't always make decisions rationally. Agreement between experts is poor, and the bottom line is, what's the threshold? What's the standard? What do you have to pass to be allowed to make your own decisions? The Lower Firm Commission recognised the multiple decision problem and said, look, let's have a bit of common sense about it, which is fine, but Mary Donnelly has pointed out it's so easy to allow common sense to override the whole principle of functional capacity. And one of my concerns is, to a degree, that if you're going to, for example, with co-decision making and representative, go to the circuit court, you're going to go there and give that decision making representative a whole bundle of powers rather than be going back there in 2 months' time for a separate decision, which leads us back really to a status outcome in which somebody may be given a whole bunch of powers over you, even though it was triggered only by your need for assistance, say in a financial decision. Anybody can lack it. Well, you can end up with an approach meant to bring out people's residual decision making and in fact entangle people who've nothing wrong with them essentially and find that they lack capacity. In the hospital one, Dr. Nelly nervous, he's making a foolish decision. Must be something wrong with him, and I'll be criticised if I let him make his own decision on that basis. I better do a mental test, or I better get a capacity assessment. Happening to some degree, a lot of requests for a capacity assessment. My last one was an enormously obese man stuck in a bed out in the community eating Cheerios. They want to know, do you have capacity? Capacity to eat Cheerios. He certainly had enormous. What are we going to do about it? Get a court order barring him from cereals? I mean, it made no sense. The protections are the presumption of capacity if we take it seriously. And I entirely agree with what Mary and Patricia before were saying. It has to be taken seriously. And it says the right thing about unwise decisions. But again, it has to be taken seriously. It's a lot of nervous Nellies out there, I'm afraid. One of the reasons we've low agreement is because these different things, anybody can tell if two examiners will agree if somebody's communicating a choice, but trying to figure out this using and weighing information is genuinely hard to parse it and to figure out how you assess it. So the reliability of that between different examiners gets poor. I won't read it, but the lack of agreement is well established, and it's hard not to agree with Brindle and Holmes saying competence judgments are value-laden, frequently subjective and inconsistent. And of course, a lot of it goes with the examiner. I love the paper about the way that you can't tell the trained from the untrained, but essentially, if you know what kind of a guy you're dealing with, you can get yourself a paternalist or a libertarian. Very easy in Galway to tell where you're going. So what threshold or standard? Dr. Nanio states he's not doing what I want him to do. Seems normal, but of course he can't be. There must be some test that'll be abnormal. So we're back again to testing and the abuse of, for example, MMSEs were mentioned, of mental test scores like that, where you're looking for something to fail them on, rather than actually doing a proper assessment of capacity and starting from the presumption. And what's it matter if you know whether or not Enda Kenny is Taoiseach for any functional test of capacity? It doesn't matter. So it's ridiculous. It happens, and it happens in Britain despite their deprivation of liberty. You get people who are saying, you know, what if she fell off the boat on our Mediterranean cruise? Safer to remain at home. And, you know, so there's Mary's quite right. Our tradition here has very much been emphasis on safety, which is why I welcome the will and preferences, and I agree with beliefs and values, as opposed to the old, inverted commas, best interests, which consisted entirely of doing what's medically recommended and safe. Part of it is due to this cognitive view of capacity, where you go back to cognitive ideas, you standardise the cognitive assessment, and even you come to it with the idea there's a lot of this stuff around, a lot of people who aren't able to make their decisions, and we need to keep an eye out for them, lest we accidentally let them make decisions. Could say that sounds like I'm not taking the tablets myself, I'm afraid, and the paranoia is coming true. But this is from the Lancet, the best ever systematic study of capacity, defined pretty similarly to how our legislation is going to go in British hospitals. And it's really, of 230 medical inpatients, 1/3 of them clearly couldn't make their own decisions. They were comatose or severe Alzheimer's or something like that. But of the rest, doing a formal capacity assessment on the actual decisions they face, so meticulous, 1/3 of them were found by this team of psychiatrists to lack capacity to make decisions. And only 1/4 of them had been identified as such by the doctors or their relatives. And the conclusion, which I described in a snotty letter to the Lancet a few weeks later, we need to regulate the freedom to decide, especially in elderly people with mild stages of cognitive impairment. Again, saying a lot of it out there. We mustn't go around letting people make their decisions in case they weren't entitled to, which is an absolute subversion of the spirit of the legislation, but is a consequence too of functional capacity if you allow it to get away from where it was meant to be coming from. Talking about the hierarchy of decision making, I'm going to talk mainly about the first two very quickly. Assisted decision making is grand, appointed by the person themselves. Minister might make regulations and all of these functions, which are all fine. So what is a big deal? It takes up a big chunk of the bill writing all this stuff down. And you'd have to say the bleeding obvious would sum it up. Because to a degree, if somebody requires assisted decision making, they actually, by definition, have capacity to make the decision. They just need a bit of help, like a lot of us do with complicated decisions. The analogy in the university is the very weak student who needs an awful lot of help getting through the exams and all hands on board. He doesn't just have one assistant decision maker, he's teachers and parents and everybody. But in the end, he passes the exam. Well done to him. And a pat on the back to his teachers and parents, etc. So what's the need for a formal assistance agreement? Very little use, I would have thought, in healthcare. Now that may be different for financial, or if they feel they're going to be criticised by somebody, but it is kind of, pretty basic. Co-decision making is a different kettle of fish. You're off to the circuit court so that you lack capacity without a co-decision maker. The decisions must be made veto. So the person has a veto, which is great. On the other hand, your co-decision maker can only agree with what you want to do. The bottom one is, no harm is likely to result. All of the decisions that are worthwhile in life involve some risk of harm. The rest of them don't matter, really. So whatever happened to will and preference and belief and values, when it comes down to the crunch, they're back to no harm can result, so not written with that in mind. So it is very much, we want to include you in this decision without letting you affect it. You can co-make the decision once you agree with what we want to do in the first place, which again is no triumph really for the law or for ethics. What is co-decision making? I don't know. I presume if you're co-decision making, you must be able to express a choice. You must have some basic idea that you're making or co-making a decision. And presumably you're just not that good at the whole reasoning bit, which is why you're borrowing somebody else's lobes to do the reasoning for you. Or maybe it's just delegated decision making, with another word, in practice. It does mention trust. I trust John Let him make the decisions. I don't want the details. He'll do the thinking for me, and I'll rubber stamp it, perhaps. So the idea of co-decision making, delegated decision making, is just very unclear from the bill, and I suspect the codes of practice will be required to fix it. What's the logic? I don't understand it. If somebody needs co-decision making, they lack capacity. And back to the exam analogy for here, this is a weak student who can't pass the exam, even with all the grinds and the help. So he cheats. There's somebody whispering the answers to him, or maybe to the delegated decision-making analogies, he gets somebody else to take the exam on his behalf. It's hard to see how that consists of passing the exam or having capacity with your decision maker. So, I mean, maybe it's convenient, it seems logically nonsensical, and maybe it's all true, but whatever else it is, it's capacity, but not as we know it. It doesn't follow any logical definition of the thing. Okay, I'm not rights of liberty. It's just outrageous what goes on in Ireland and has gone on forever. The legal doctrine of necessity has been used. The Court of Human Rights in the case of the Bournemouth reaffirmed this. Detaining somebody in a nursing home, it isn't enough to say that they need to be there or it's not safe. There have to be the safeguards. They aren't there. Mary's quite right, the deprivation of liberty safeguards have been found not fit for purpose by the House of Lords. Remember, they came to it saying they're not enough and they're too complicated. They weren't saying it should be gotten rid of. They're recommending a change in legislation so that people can't be deprived of liberty so readily, which is exactly, so we could learn a great deal. It doesn't look like their safeguards are going to be for us and will be unwieldy. The answer is to keep them simple and don't go around depriving people of liberty. It's a big, big deal to do so. So we've no protections, all of the words are fine, but essentially where we are is elder abuse. You take a vulnerable bunch of people who want to be at home, you admit them against their wishes, you don't recognise that there's need for procedure, they can't appeal. To add insult to injury, if they protest vigorously or try to get away, they're aggressive, they're violent, they're absconding, in which case you may as well sedate them because they're not consistent with the smooth running of a home. And then to add insult to injury, they have to pay for it themselves. You don't do that to others, and the state is implicated because the state funds it. So the idea you can say anymore, we don't know what's going on, you're funding these detentions through the fair deal and other mechanisms. So completely outrageous. It's not just though about capacity. Best interests I'm wary of, but what are the interests? And I use this slide generally just to annoy people in healthcare. It'll be nice for you to be with other confused people. You'll be less confused. Well, you won't be actually from the evidence. You'll be happier. No, you won't be really. You'll get better medical care. You will get better nursing care. You won't get better medical care in terms of chronic disease, antipsychotics, etc. You'll live longer. Well, no, actually you won't. So it's very hard to see how the benefits go. I know that's a very partial view, by the way, folks. It doesn't do the whole thing. But it does show that just saying somebody lacks capacity doesn't mean you lock them up on the grounds that now we decide we can do what's medically safe. What are the possibilities with this bill? I'm almost through. The bill will be effectively ignored. In a lot of cases it will be. It's too complicated. In healthcare decision, a lot of the provisions won't be used. It'd be too much trouble to go to the circuit court, and there'd be an outbreak of informal decision making and co-decision making and all kinds of things. The other one, it'll be taken too seriously, and we, certainly healthcare professionals and old age psychiatrists and geriatricians, would be awash in people trying to cover their posteriors, looking for capacity assessments every time somebody wants to do anything that looks a bit out of the ordinary. And the other one, the risk is the spirit of it, which in the basic principles is good, will be subverted by all this multiple decisions being bundled together and by our judges not behaving the way, as Mary's quite rightly said, Elder Gill, Mumby, some fine libertarian judges in Britain, we need some of the same. Probably all three of them will occur at the same time, by the way, just to make it complicated. Suggestions, the working groups and codes of practice, there is a lot of work to be done there, and we can hopefully keep the spirit alive in them. The presumption of capacity is the basic. It shouldn't be challenged, the trigger, and to a degree we're back to the outcome approach, but the trigger must be substantial before you go anywhere near capacity. You let people live their lives and make their decisions. unless they're doing something that looks particularly irrational or inconsistent with where they're coming from. You don't go around screening for it, trying to take away people's decision-making capacity willy-nilly. The threshold should be nice and low and attainable, and you only go there if you can actually do something in practice. I was interested, one of the examples of Patricia, but capacity to take or to refuse consent to take medications or chemotherapy. Because again, you go back to, does it matter? I want you to take this tablet every day for the rest of your life. No. But you lack capacity to say no. So what? What are you going to do? Get a court order that he has to take his medications or he can't take his cereal? So again, it has to be pragmatic. Sometimes capacity doesn't matter. If a person has an effective veto over their own life, well, so be it. Just accept it gracefully. Okay, so the capacity bill unfortunately isn't going to solve all of the issues that we have. There's a lot of work to be done, and in the end maybe there are some people who shouldn't make decisions, but for the majority, carry on deciding. Thank you.